Welcome. My name is Cristina Nunez. I am a second-year internal medicine resident from USF at Tampa, Florida. I will be presenting a case on acquired factor VII deficiency and its association with stage 4 lung adenocarcinoma treated with pembrolizumab and radiation therapy. Coagulopathies are rare disorders. Factor VII deficiency is the most common of the inherited coagulopathies, with an incidence of only 1 in 500,000. Even fewer cases are reported of acquired factor VII deficiency, which means you were not born with a genetic deficiency, you have acquired the deficiency. So let's dive into the case presentation. My patient was an 84-year-old male farmer who had been recently diagnosed with stage 4 lung adenocarcinoma. He had started treatment with pembrolizumab and was status post-radiation therapy. He presented to the emergency room with left lower extremity pain that started 4 weeks prior to presentation. Physical exam was remarkable for a borderline low blood pressure and tachycardia. His left leg was swollen, tender to palpation, and had yellow discoloration. Labs were remarkable for normocytic anemia of 4.1 grams and acute drop from a normal baseline hemoglobin. Patient was hemodynamically resuscitated with intravenous fluids and 5 units of packed red blood cells. CT with contrast revealed a 20.9 centimeter intramuscular hematoma without evidence of active bleeding. Since his PT was prolonged in admission, we sought a mixing study to test for deficiencies. After mixing the patient's plasma with normal pooled plasma, his PT corrected. Given the fact that only PT was prolonged, we suspected deficiency in the extrinsic pathway only. Factor VII deficiency level was low at 33, when the normal values ranged from 60 to 150. Since the patient did not have active bleeding, he did not benefit from recombinant factor VII administration. Patient remained hemodynamically stable, hence was discharged with hematology follow-up outpatient. This case adds to the scarce literature of acquired factor VII deficiency. Most of the cases reported have concomitant malignancies. Some solid tumors have been described, but most cases are hematologic in nature. What most caught my attention was Camret's case report of a patient with urothelial carcinoma that was also treated with pembrolizumab and radiation therapy and subsequently developed factor X deficiency. It made me question, is this a disorder associated to the tumor itself or a consequence of its therapy? Some authors have postulated theories of the pathophysiology of this deficiency, including the possibility that since chemotherapy and radiation therapy increased the vascular permeability of vessels, they exposed intravascular factor VII to the extravascular tissue factor, hence creating consumption of the factor. To our knowledge, this is one of the first cases of lung adenocarcinoma associated with isolated acquired factor VII deficiency in the setting of pembrolizumab and radiation therapy. Further studies are required to determine if an association exists between these therapies and factor VII deficiency. Thank you.